Hello and welcome to this RPTH research recap, where we dive a little deeper into the science being published at RPTH. My name is Matthew Cormier, and I am currently finishing up a PhD at Queen's University in Canada, studying hemophilia and anti-factor VIII immunity. I am the associate editor of social media for RPTH, and I'm very happy to be with you all today. Just a comment for those joining live on YouTube or Twitter, there will be a discussion period for this recap. So if you have any pressing questions for our speaker today, please leave them in your respective chat boxes, and we will try to answer all of them in our discussion period later after the presentation. So I'm very excited to introduce you to Dr. Jacqueline Hernandez-Nino. She's an internal medicine physician currently in her last year of the K-12 program in emergency care with Indiana University. Her main research interest is on venous thromboembolism, with a recent shift in focus to the psychological impact of VTE. She has recently published an article at RPTH discussing the impact of communication at the diagnosis of venous thromboembolism, a very important and often under-discussed topic in VTE care and research. So Dr. Hernandez-Nino, you have the floor.
Okay, thank you so much for your introduction. And it is a great pleasure for me to present our recent publication in RPTH. And I think we can have the slides now. Okay, thanks. So again, our paper is Communication and Diagnosis of Venous Thromboembolism, the lasting impact of verbal and nonverbal provided communication in patients. So the patient healthcare provider relationships requires trust and effective communications. As we know by previous work, that effective communication with patients can improve their health outcomes. Now, this concept of trust and communication is particularly important and challenging in the emergency care setting, where physicians must communicate diagnosis, treatment options, risk, and prognosis of life-threatening conditions within a short period of time. Now, most of the paper describing this patient healthcare provider communication has been done in the non-urgent setting, where a prior relationship has been established. However, almost no resource had examined communication in emergency situations where the decision has to be made within hours. Now, the diagnosis of venous thromboembolism and his treatment does represent a model system of an emerging condition that requires immediate decision-making regarding optimal treatment choice, and where both, the failure to treat and the complications for treatment can be life-threatening. So to address this knowledge gap, we report in this paper the patient's experience and the patient's perceptions about their communication with providers during and after the diagnosis of venous thromboembolism. So now we use a qualitative methods here, and using semi-structured interviews. We did publish a detailed methods description of this study also here in RPTH, and the name is the use of qualitative methods in venous thromboembolism research. So we included participants who have been experienced symptomatic VTE, either as a pulmonary embolism, deep venous thrombosis, or both. But we also include, we want to include a wide variety of healthcare experiences. And this includes, patients who were discharged home from the ED, also patients that were admitted to the hospital and received a little bit more advanced management like reperfusion therapies. We include patients with a first time in VTE recurrence, and also, a wide variety since the type of diagnosis. Again, at least with 6 months, but I think one of the patients have about 9 years since the diagnosis of VTE. All our patients signed informed consent before the interviews were done, and most of the interview lasted about 75 minutes. So what were the results? Between June of 2019 and May of 2020, we completed 24 interviews. And the content analysis revealed as a major theme what we call the increased anxiety and stress after communication. And as you can see in these diagrams, there were 4 categories that influence this theme. And what I'm gonna do now is gonna go a little bit deeper on each one of these categories and how this influence our main theme. So the first category that we have was the word choice used by healthcare providers. As you can see here, the first quote with a 51 years old woman, she was told by the healthcare provider, you have to have this surgery now because if not, you're going to die. Then she said after she heard that, so she just broke down and cried and could not think no more after that. So the participants can interpret this use of alarming language as a way to convey a sense of urgency. They say that healthcare providers mainly use this type of communications where we're trying to convey, the treatment options or the prognosis for the patients. However, all these communication kind of made the patient feel like he didn't have any other options or they didn't have time to make decisions. Actually, we have one participant that reported that this type of language, it was used as a scare tactic by the healthcare provider. Some of the participants also described how the providers use the medical jargon to explain their condition without realizing that the meaning was not clear for the patient, and they has to, ask the physicians, I really don't understand what you're saying. Participants also describe the use of frightening metaphors by healthcare providers to kind of alarm that this imminent doom was coming. And you can see that a 60 years old man who say that their providers say, you are a walking time bomb and we need to get you right away for surgery. So, medical jargon, these misplaced metaphors and alarming language were identified by participants as a source of, anxiety. Now, the second category that we have was what we call the incomplete information by healthcare providers. So the majority of participants reported that at the time of diagnosis, they had no prior knowledge about the blood clot. However, some participants felt like the healthcare providers failed to effectively explain their condition even after the request for clarification. You can see in my second quote here, we had a 56 years old woman who was told by the provider to take the pill every morning and don't miss it. And she said, well, what happened if I miss this? And he said, don't miss it. That's all what he said. Also, some participants expressed they wish they had a little bit more of transparency regarding the severity of their condition. And all these reflections kind of led participants to search for more information. And as you can see, the patient in the first quote, 65 years old woman, she was told that she had a saron embolism, and she said she went to the internet to look for this information. She couldn't find anything. So it seems like, looking for that information through other sources and other healthcare providers can increase fear and kind of lead to the development of new worries in the patients. Now, the other category is what we call the inference created by nonverbal behavior. Participants often describe making inference about their situation based on providers' nonverbal communication, which resulted in increased anxiety and confusion. So, for example, providers' facial expressions were often used to estimate the severity of their condition. Also participants reported that they grew, really concerned as more physicians entered the room to conduct, their examinations because they kind of equate this, busy environment to a poor prognosis. Some of the participants even described that they feel neglected as the environment, grew busy. When I was doing these interviews, what really caught my attention is that even months and years later, participants were able to recount the moment that they began to realize that the severity of their condition. And surprisingly, a lot of those moments were just based on nonverbal communication. And last, the last category that we labeled was the imbalance between fear and reassurance. So participants report that the lack of their understanding about their diagnosis or treatment, influenced their safety perception of the care that they were receiving, which of course, increased that threat perception. But equally, however, in a very small number, I have to say this is the only positive things that I'm gonna say about communication. A participant's sense of safety increase when the healthcare providers truly explain their diagnosis and their medical decision making in very simple terms. When these conversations occur during the type of diagnosis or before treatment was provided, participants really felt comfortable, with the diagnosis and the treatment that was recommended. So you can see that second quote there, a 56 years old woman who say, this doctor explained everything through the family, the sons, their wife. Everybody came and listened and got the information that they needed. And she really felt fortunate that they had the care at that hospital. So, as a discussion, we say that, our findings cannot reveal that healthcare providers can unintentionally communicate with patients diagnosed with VTE in ways that fail to inform them about the disease process and by ways that unnecessarily increase fear and concerns, causing persistent anxiety. Now, I think also that our findings, highlight opportunities to improve these communications in patients with acute venous thromboembolism in the emergency care setting. For example, the use of basic language and avoiding that medical jargon can improve the patient understanding, can prevent the development of barriers, and they definitely can enable patients to participate in decision making. Now, what I know that research has shown that the use of metaphors and hyperbole may improve communications. Actually, our findings indicate that the use of these metaphorical expressions to explain medical concepts can definitely evoke fears in our patients. For example, that phrase that I show you that, you're a walking time bomb to describe patients with venous thromboembolism, may used to convey, the severity of the situation and maybe the importance to start the treatment right away. And as I know this, while they're well-intentioned, such a language like this, or, those statements that usually, providers can use, like, you could have died, we don't, make the diagnosis today, or I have seen patients die for what you have. This type of language really may increase the patient's anxiety level. So I think that instead providers can speak about blood clots as being safely treated if we promptly do the diagnosis, which I think also will reinforce the importance of seeking medical attention should future symptoms occur. So again, we know that healthcare providers, can use these metaphors and hyperbole to clarify diagnosis, but definitely they should be aware that they should not be used to intensify, fears in patients. Now, and lastly, participants reach many conclusions about the diagnosis and prognosis based on nonverbal communication. And of course, this study was not designed to determine how nonverbal actions could be improved, but other studies have suggested that providers should, be seated, relax the facial muscles, use natural voice, and definitely maintain eye contact when and try to show understanding when they're discussing this important medical information. Um, our study did have some limitations. This sample was limited to just 2 hospitals from one city in the Midwest of the United States, and definitely like ethnic diversity. Also, we do not have control over the influence of the ED environment on patients' recall, which could have contributed to the perceptions depending upon the pace and the acuity of any given day. You know that ER departments can change at any time. And lastly, remember these interviews were only from patients and it did not allow any insight into the awareness or the intentions of the clinicians. So I guess as a conclusion, we'll say that this qualitative study revealed multiple opportunities for improvement of communication in emergency care patients with acute venous thromboembolism. I think the future qualitative studies could continue to explore ways to improve this communication from the perspective of patients and providers, including ways to improve, external systemic factors that negatively impact the patient-provider communication. And I think that's all that I have today.
Wow, thank you, Dr. Hernandez Nino, for that great presentation. Specifically, speaking for myself as a non-clinician, it's surprising how these such minor comments, what it seems like to me, anyways, a lack of effective communication about the condition and the treatment that the patients are going through, or these non-verbal cues, can have such a large impact on the experience of these patients and really alter the course of their prognosis. So thank you for that. And just a reminder, if you have a question for Dr. Hernandez Nino, please leave it in the chat box. But to start, I have one question for you. So why do you think that this, you mentioned in your introduction that this is not really a commonly investigated area of research, especially in acute care settings. So why do you think this aspect of patient care has not been looked at in urgent settings? And maybe in addition to that, what are some inherent complications of this type of research?
But I think this is a real question and really important question. And I think the basic answer for this is, patient-centered outcomes is really new. This just started back in 2001. So we really been doing this type of research just for about 20 years. And, another big problem is, funding for this type of research. I think PCORI budget to support this type of research is very, low for all the things that need to be funded at this time. So I think that's one of the biggest problem, and again, we're thinking about complications. This type of research will need a lot of resources. It's the emergency department. It's open 24 hours, 7 days, or 365 days of the year. And again, this is our moments of crisis for patients. And again, I can see be a real challenge just trying to get, consent form when the patients come in this type of crisis. So again, that will be the 2 points that I will consider, why this research has not been done.
Yeah, and kudos for you for doing this research. It's really great. Interesting. So second question I have pertaining to your population. Obviously, you represented or you provided some recounts of a lot of these patients that were going through this VTE diagnosis. But I was wondering if there are any differences between some of the factors in the patient population and between age, between sex, or any other factors in the patient population that could have influenced the interpretation of or the experience of the VTE diagnosis.
Yes, definitely. And actually, in that first paper that I say we published about the methods, the methodology of this study, I did mention something there. And what I noticed mainly was when I was doing the interviews and I was kind of assessing and asking, that was at the beginning. And I was using, kind of direct words as anxiety and fear. I did notice that definitely it was a difference when males were answering these questions. If I use straight that word, anxiety, fears, they will deny. But throughout the conversation and throughout the interview, I did see that these patients show, they were worried, that they had anxiety. However, they were very reluctant to say it as a word, but they will admit it within, other words. So yes, it's that definitely, and like I say, I did mention that in that methods paper.
Perhaps a future direction.
Yeah.
And the last question I have for you is actually a question from the YouTube chat box, particularly from Dr. Mary Cushman, and she wants to ask this very important questions for the clinicians that are taking care of these patients with the VTE. So, how can clinicians recognize whether these factors are at play in their patients? Potentially as a way to interrupt or intervene when the communication barriers might be degrading.
That's a really important question, and I think providers always should be checking the patient understanding. They should when they're talking to patients, I think everybody's very familiar with the teach back and, just kind of tell me you understanding. But I think also, but some patients even, will tell you and really they, and then you will ask, and, did you have any questions? And patients will say, no, I don't have any questions. And I think another approach to that will be, for example, to say to patients, patients diagnosed with venous thromboembolisms or, with PE, sometimes want to know, why did I get a blood clot? And then you go and answer that question for the patient, and kind of that may, make the patients, think about other questions at that time. So, just keep checking back on the understanding. Again, teach back is good, but also if they don't say anything, just kind of give some questions, answer to them, and maybe that can open it up a little bit more questions for the participants to ask.
That's a great strategy, and hopefully those listening to this talk can take that into their own practice and hopefully improve the experience of the patients that they're treating. So Dr. Hernandez-Nino, thank you so much for presenting your work and giving us some insight into the impact of words and also nonverbal communication that healthcare providers can have on patients being diagnosed with VTE. So I hope your viewers, I hope the viewers will read the full details of your paper on our website, which is rpth.isth.org, and take advantage of our science-themed waivers. These are specific themes of science or medicine that span a few months. And if you submit your article during this time and it's under that specific science theme, it can be eligible for an open access fee waiver if accepted. So the current theme focuses on research and disparities in healthcare. So Dr. Hernandez-Nino, thank you, and I hope you will publish again in RPTH. Thank you all for watching.
Thank you.